keep it as practical, as possible. And if there are any doubts later, I can take it at the end of the presentation. So I'll just share the screen so that we can begin. Right. All right. So I think if it's visible, I can begin. Dr. Shanov, everything good?
Yeah, everything is fine, ma'am. Please proceed.
All right. Thank you. So this is the topic, and the reason I chose this topic was because we all do dentures, and obviously there are a lot of problems that we face many times. But this is especially for I thought this is one topic which everyone is not may not be very well versed with, because denture relines are nothing new, but yes, there are newer materials that have come, and those are the ones I'm going to show some videos as well, so that we are comfortable using them in our practice. All right, having said that, let's just go ahead. Now, all of us have those patients, where they come to us again and again. There are times when we have checked everything, we've checked the occlusion, we've checked the extensions. We feel that now the patient should be comfortable, but there are definitely some patients who just keep coming back. And I'm not saying that relining is a jugaad for that. But the point is, there are times when it really works once we understand, which case is ideal for it. So many times, such the patients who keep coming back. It has happened with me also in the past that my thought is, okay, please, if that patient doesn't come back, I have done everything. That point where it was hurting, the ulcer which was coming, the denture getting lifted, all those things were happening. And my thought was that, okay, somehow if the patient gets comfortable and just does not come back, because there are some patients, all of us have those skeletons in our closet, those patients who keep coming back, and are nightmare patients. So there are a lot of ways to deal with these issues. So we definitely, there are problems that need to be solved, and that is a separate topic completely. But a small part of all of this, assuming that everything else like occlusion, the extensions and stability, things are fine, almost fine, then there is a small part called as denture relining. It can be lab fabricated, or it can be chair side. It can be hard or soft. The point is that that is a small part which can make our lives easier. And that is what I'm going to discuss today. So what is reline? Actually, what is it? So basically, it is the resurfacing of the fitting surface of a denture with a newer material. Now, how many types there are? I'm not going to go too much into theory, but just some basics. That is, we can do it. Hard relining can be also done chair side, as well as the soft relining. But there are ways of, you can just make an impression and send it to the lab, and the lab will do the relining for us. So that is a lab reline or indirect reline. The short-term relines are also called as tissue conditioners, and the silicone long-term relines are the ones which are called as permanent relines. But there's really nothing permanent in life, and that is why they're long-term relines, because the teeth do not last permanently. The dentures have to be changed after every couple of years, and so does the reline. All right. It can also be described as or classified as, with the technique that we are using. For example, the direct impression technique or the functional technique. Direct is that we make an impression and we, send it to the lab. Or a second functional technique is that we reline it with a soft tissue conditioner, and we let the patient wear the denture for a couple of days. And once the patient comes back, we send that denture to the lab, because now it is molded according to the patient. All right. Now, short-term or temporary soft tissue conditioners, there are a lot of companies which have them. Like GC has, there's a which also has it. This is the GC one. So basically, they do not last very long. They absorb like stains, coffee, things. So they get heavier, and that is why they need to be changed. So when should we use short-term tissue conditioners? That is when we are trying to condition the tissue. That is, if there is, if there's an extraction that has been done or an implant that has been placed. So we want the tissue to, heal. And that is when we use the short-term tissue conditioners. These are the indications for that. Basically, it's for conditioning the tissue where we are not looking at using this material, the reline, for very long. It is just for a short period. All right. Now, long-term liners are usually made of silicone because silicone does not absorb things. But in spite of this, that silicone materials do not absorb, still you will see that, at the edges, the relines are peeling, or, there are bubbles which are there. So what happens is that whenever we are using the relines and placing it on our denture, if you are not following the protocol or the instructions given by the company, because they specifically mention 1.5 to 2 millimeter of thickness of material. So a lot of things are there which, if we do not follow properly, that is when the material tears. If it is very thin, it will tear. Or if there are a lot of air bubbles, or somehow we've hand mixed it or didn't mix it properly. So in those air bubbles, the food gets lodged, and eventually they start getting spoiled. All right. Now, if the dentures no longer fit the residual ridge, we can, or the retention or stability is lacking, then we can use relines, short term or long term. Short term for some time, and long term for if you're looking, as a permanent solution for a year or two, which needs to eventually be changed. But it is not. We have to ensure that occlusion is acceptable, and the denture is basically proper. There are some issues to it. Let's say it's not as stable as we are looking, we want it, or it is not as retentive as we want it to be. And we feel that with relining or changing the surface, we can, achieve better results. But it does not mean that a very old denture with reduced VD or, can be relined. That is not the goal. Yeah. All right. Now, just because the patient has come to us and has said that my denture is loose, old denture or a new denture, does not mean it is an indication for relining, because there are a lot of things we have to check, as I have said, for old dentures. And even if it's a new denture, and the patient, it's not retentive and we want to reline, we need to check things like extension, occlusion. What is the cause? Is it that the surface is the problem? If that is the case, then we can definitely reline. We can even go for a hard reline, lab fabricated. But if it's overextended, we may reline, we may do whatever, it's not going to stay. Or if the occlusion is not proper, it's not balanced, the patient has lower natural teeth and they are all in different levels, and that is when, so whenever the patient will try to chew, because of the discrepancy in forceps, it is going to fall off. So these are not the best cases for relining. We have to solve the other problems before we reline and understand, is it even needed here. Now, as I said, that there are hard relines and soft relines. So hard relines technique, basically what we do is that we relieve the borders. Okay. If we are taking the border as well, borders are 2 mm short of the vestibule. 1.5 to 2 mm is what the company recommends, because that is the thickness what is needed. We can also do hard reline chair side. I have the Tokuyama hard reline with me, and I use it sometimes, and it gives good results because it does not, there's no heat that is generated. There is no heat that is generated, and that is one of the reasons why it is specifically for chair side use. So you relieve the borders by 2 mm short of vestibule. Now it's very difficult to maintain this 2 millimeter thickness all over the denture, because if we are just trimming arbitrarily, some places it will be 1 mm, some places 2, some places 0.5, right? But if you want a proper 2 mm equal, everywhere, for that, we need to make guide grooves. To basically take a burr where we can make ditches of 2 millimeter or 1.5 millimeter, okay, and then smoothen those ditches. So what happens is that we are sure that we are getting the 2 millimeter. How to maintain the VD? There are different techniques to it. Now, if the borders are involved and we want to maintain the VD, then we will have to leave some areas which we are not trimming off. Okay, so I'm going to show you a case as we are done with the presentation, one of my cases, and then we'll know. So first thing, check extensions. Overextensions do not work. You will have to reduce it. It has to be underextended for the reline to work. In the, just with the marker, mark the area where we feel that, okay, maybe this is where, 1.5 to 2 mm is done, and we need that much material, or, or the space for impression to come for a hard reline. So just mark it with a marker, trim it. The border reduction is important. If you are, just reducing very little will not work. If you are trying to, basically make an impression, which we're going to send it to the lab. So border molding is done, and then after the border molding, palatal vents are created. Just because it is a denture we're going to use does not mean that we do not create vents. Many times we feel that, oh, it's a good denture, it's a new denture, how can I make holes in it? The point is, if we do not make the vents, we're not going to get good results. And once that is done with any light body or ZOE, whichever final impression material we want to use, we can just use it and make the impression. Then we send it to the lab, and if incorrect seating is there, improper plane of orientation, because many times see denture patients obviously are a certain age, and if you are going to place it in the patient's mouth and the patient does not close properly, or what, as I said, there's occlusal discrepancy, there will be incorrect seating, and then the pressure is not equal, and that then we'll not get a proper impression, and when the final reline denture comes, that will also not seat properly. So that is one thing we have to initially understand. Once we send it to the lab, once we are happy with the seating, happy with the impression, so patient has, we've made the impression, we've made the patient bite, because we are doing one jaw, the other jaw the patient has to bite in centric, and everything is fine. And then after that, we send that denture, it's upper or lower, whichever we are doing, to the lab for the lab indirect technique for hard relining. Once we send it to the lab, that's how they pour everything, and then they can, if they are doing compression molding, then this is done. But it's much better to go for injection molding in such cases. So there is, there is a lower chance of discrepancy, and the relining is, much more stable, because if you are heating the whole denture again, that is not very great. So this is injection molding would give better results in relining. Now, relining contraindications. As I said earlier, every case is not a reline case. Just because it's loose or it's unstable, it's not fitting, does not mean that we reline and ho gaya. So this is not a jugaad we are looking at. We are actually, we have to understand where it can be used. So one of the main contraindication is worn out dentures, because an old denture where the teeth are all treated and patient is closing in a pseudo class 3 or things like that, we cannot reline, because the denture itself needs to be changed. Then vertical dimension loss is a lot that which cannot be compensated with reline. Significant inflammation and poor denture aesthetics. If the patient has denture-related speech problems, they're not going to change with reline. So these are the major contraindications for reline. So severe tooth wear, as I said, because if the VD, is reduced, patient has been old denture wearer for many years, obviously the teeth get treated. So that is something you need to change the denture. Severe occlusal wear, the same thing. So I'm going to show you a short video as to how, soft relining is done, where this is done on a model. But I just want you to kind of get a feel of how it is done when the borders are not involved, because the relining can be done in two ways, chair side. We can involve the borders, or we can leave the borders. If a patient has, let's say, a mylohyoid ridge which is very sharp, or there is a very small very small tori on the mandible, or things like that. So where we feel that, okay, just we can, or it's a bony, there are bony spicules and the patient cannot go ahead with any surgical procedure further. So in those cases, we don't need the borders, because our borders are good. Retention is fine. The problem is whenever the patient is chewing, it is hurting. So we keep trimming the area, but it is still hurting, because there's a bone and very thin mucosa, and then there's a hard denture. So it keeps hurting. We keep trimming, and it does not really work many times. And so in those cases where it hurts, but there's no issue with denture stability or retention, then we do not need to involve the borders. And this is just a video to show how to do it. So here, I don't know, I think you can hear it probably. So basically, The impression surface has to be prepared, as I said, that you can take a round burr, a burr of a certain diameter, so you know how much you are cutting. So make a ditch inside the borders, because here we are not involving the borders. So make a ditch with a certain thickness inside the borders. Here I'm just doing half the denture to show how it is done. Once the ditch is made, we can create serrations. We can mark it with a marker so that we are sure, we don't get confused. And then we basically remove the part 2 mm part inside, because here we are not touching the borders. So this is once we have removed around 1.5 here. Here we don't also need to worry about the VD, because the borders are still there. So when we are not using, basically not taking the borders in our trimming, then there's no problem, because borders, when the patient choose, the VD will not go down, the borders will keep it in place, right? So just after removing 1.5 to 2 mm, leaving the borders, smoothen it nicely. You can use a sandpaper. Once it is smoothened, just mark the area you want to reline. I'm doing half a denture here to demonstrate. It can be it's usually the full denture, or it is a small area where, as I said, the bony protuberance is there. You don't have to reline the whole thing. You can always just create that part where you feel the problem is. So after we have marked with a marker, we take a primer. Now, primer is basically nothing but a bit type of adhesive, okay, for the reline. So the company suggests around 2 to 3 coats of this primer in the area where we want the reline to be done. Ensure that we put it nicely, because it keeps drying. So many times we don't know where we have put and how many layers we have put. So just put it nicely. And once the surface is completely coated, let it dry. Within few seconds, it will dry. And then we use, there are two types. You also have a hand mix, but don't use a hand mix reline. Use a gun. Always bleed the material, remove the the beginning of a little bit of material, and then you inject it. So inject it slowly. Don't try to push too much. The swirls which come with it, that will mix nicely. And then you just put it, fill it basically inside where you have trimmed, and you put the adhesive. Once you are filling, make sure that there are no air bubbles, because air bubbles will create problems. Once it is inside, you fill the whole thing. Now place it in the patient's mouth and do the movements. Once you've done the movements, ask the patient to close in centric. Then let the patient sit like this in centric when it is closed for the time that the company has recommended. Every company says around 5 to 7 minutes. So that is around 5 to 7 minutes by the clock is when we for the how long we have to wait, and make the patient close completely. Now sometimes patients don't, they are old and they don't, and the upper denture is not that great, and you're doing it for them and they don't close properly. So for that, there are ways of doing. I'm going to show you some photos later as to how to ensure that they close properly. Okay. Once we have to wait for, as I said, 5 to 6 minutes for the reline, the silicone material to set. Once it is set, it is very easy to remove the excess. Okay. Take a BP blade, a new BP blade, obviously, because we do not want to create a rough surface. Take a BP blade, and you've already marked with a liner inside, right, where our extensions are. And then so these are basically two types of relines that I have used here. They are different colors. So just move it around the borders, what you have marked, and then just peel it. It easily comes off. It is very easy to peel. But if you still feel that in some areas, if the thickness is more, or it's difficult to remove it, then you can also merge it a little bit with a buff. So Tokuyama provides these buffs in their kit, but there are obviously different types of buffs which can be we can get it at trade fairs and all. So you don't have to buy a specific material to get a buff. It's like a silicone buff to just merge it. Okay. Now, hand mix versus auto mix, there are hand mix syringes available where you can mix it like both the materials. You can base and catalyst, you can mix and then load it. That I would not recommend, because 100% there are a lot of bubbles. I'm going to show you another video as to the type of materials that are available in the market and which one you should actually buy. Okay, so it is totally your call, seeing the budget and the viscosity of the material. we can decide which ones we need. Um, so I'll just mute it and yeah. So the thing is, if you see this shiny thing, that is an air bubble, okay? So if we are going to use something like a hand mix, or if we are not going to properly inject it everywhere, and we keep lifting while injecting, then air bubbles come, and that is how it looks. It looks very shiny because it has not even touched the tissue, okay? While we have relined. So this is how a big air bubble or looks. Now, I have no idea what I'm saying in the video, but there, as I said, there are two paste systems. You have hand mix also. So I have like 4 types of soft chair side relines with me in the clinic, and this is like this also I had bought because initially cost is a thing, and we have to decide what works for us. And I had tried it, but that was a mistake because however the company recommends that you use a circular motion and do it properly, fold and flatten, so that there are no air bubbles. It is impossible, it is literally impossible to not have air bubbles. If you are using a hand mix soft reline, it's going to have a lot of air bubbles. They may not be as big as the ones I've shown, they may be as tiny as the ones you see here, but there are air bubbles, and these air bubbles or air pockets, that is where the food gets stuck, and that is how the reline gets spoiled. So we tell the patient it's going to last you for a year or 2 years, and if in 3 months the whole thing comes off, or is it's peeling, it's not a very good thing, right? Because we charge the patient and we promise something which we cannot deliver. So auto mix is what you have to use. It can be used with 1:1 gun. So this one is soft reline tough medium from Tokoyama. So if you have tough medium, that means it's a long term chairside reline. But if you have tough soft from Tokoyama, that's a tissue conditioner. Okay. And there are other companies which I've used. There's Molosil Plus, there's Silagam Comfort from DMG, and there is this last one, Reviver from Detax, I think. Yeah. So I've used all of these, and here personally, all companies say that it's going to last for 2 years, but it does not. In 6 months' time, it starts peeling and it starts smelling. So in my experience personally, the Tokoyama one, I mean, I'm not trying to sell any product here. Believe me, no one's giving me any money. But the thing is, this is something which works in my hands. I feel the results which I get are better because this is very low viscosity. So it does not increase the VD when you are doing it. Whereas Silagam Comfort from DMG is also good. It is relatively cheaper. The issue is that it is very thick, the material. So the patient feels a lot of comfort. It's like Dunlop, but the issue is that it's going to increase the VD. Reviver and Molosil are kind of land between these two when it comes to viscosity. So we can see what do you want. If there's a spicule you want, then you use a thicker, higher viscosity material. And if you just want a better fitting denture, then you can use the Tokoyama because it has very low viscosity and the seating is very nice. Now, there are a lot of mixing tips which come with these companies. Every company has a different length and a different thickness for mixing. So they recommend that the number of twirls which are there, so we mix many times, right? So I mix it, it works, but it's not recommended because they say the number of twirls that are coming should, that much is needed for a proper mixing of that particular reline. So it's better if we just stick to what they are suggesting, right? All right. Now, I discussed how to do a hard line. Basically, hard reline, which we are sending to the lab, is just remaking the impression, right? Remaking the impression and sending it to the lab, and that surface of the impression, the lab is going to change it into acrylic. Now, if we are doing a soft chairside reline, the basic removal of the material, the 1.5 to 2 millimeter of, relieving the borders or from the inside is the same. That does not change. Why do we need 2 mm? Because as I said, the recommendation of the company is that 1.5 to 2 millimeter thickness of the soft reline material silicone is necessary for it to work for 2 years. So that is the reason they are saying it. So it's not always possible, but we try to keep it at least 1 to 1.5 mm. You need it. Thinner than that, it is not going to work. Now, this is just a case, there are patients when we have teeth for some reason and we cannot remove it. Now, if we make a normal denture and we create a lot of space around these teeth so it does not rock, many times when the patient is chewing, it moves, and patient will come back to you and say, it's hurting me somewhere, and you'll say it is always going to be the area around the tooth, and that is a problem. And so in these cases, soft relining is a good option. So how much to trim, where are the areas, it's all, if we are doing it just arbitrarily trimming the denture from inside, as I said, it does not give you amazing result. It's better to be specific. So you have these something called as PIP, that is a pressure indicating paste. Okay, there are a lot of companies which have it. Kerr has it, Colteen has it. It's basically when you put this paste inside the denture and make the patient wear the denture, wherever you have high points, like wherever the teeth are there, bone is there, whatever from those areas, this material will go off. So when you take it out, you can actually see, okay, this is the area where I have to trim more, or I'm more higher thickness. I need higher thickness of the reline. Once it is used and the denture is cleaned and dry, sandpapered, not obviously polished, but sandpapered and clean, that is when we put the primer or the adhesive. 2 to 3 layers, as I told you, place it everywhere. Then we inject the material, okay, whichever company we are comfortable with or what we have in the clinic. Once it is injected, we place it in the patient's mouth properly, do the movements, and whatever we do in border molding, but gently, because if you press too much, the whole of the material is going to come out. So you have to do it very gently and then ask the patient to close. Once it is done, 5 to 6 minutes have passed and the material set, take it out, remove the excess with a BP blade. Very easily, you can just peel off wherever you've cut with the BP blade. Okay, it does not leave any residue. But always cut at an angle of 45 degrees, what is recommended, so that it's not like a butt joint, but like a thin thing at the borders. It does not irritate the tongue if it's at the lower. And if you have generally with good companies, many times you don't really need to use these stones and buffs, etc. But if you feel the merging, then you can use like a silicone buff, which is available. So this is one thing. Now there are a lot of problems. It's very easy to show a case and say, okay, this is how it is done, and and now go do your relining. It's very easy to say like that, but can we actually do it so simply? So we should understand the problems that you will face, because I have faced all of them and I still face many times. We all face. So problems in execution, that what can go wrong when I do my relines, right? All right. So positioning of the denture while relining is very, very important. I'm going to show you a photo also of how to do it, but that is one problem you're going to face. The second problem you're going to face is raised VD. If you're using a reline which is thick in consistency, in viscosity, that is like, for example, Silagam Comfort. It is so thick that when you are injecting it, you have to put like a lot of pressure for the material to actually mix and come out. Whereas when you use Tokuyama, it is much thinner. So if you have a bony spicule or you want some thickness there to, so that doesn't hurt the patient, then you need a thicker material. But the issue is it's going to raise the VD. So how to ensure that the VD is not raised? Third is occlusion. Okay. We have done the relining, everything, and we forget to ask the patient to close. So where we are holding the denture, if it's upper or lower, and we don't ask the patient to close before it sets, then what will happen? The denture, see, there are no teeth, right? So it's like how much pressure I am applying, how much pressure that day I am applying, it all changes. So if it is not in place, when the patient final denture comes and patient closes, teeth are not going in maximum intercuspation. So occlusion can be an issue. Then closing in correct centric. When you put the dentures in the patient mouth, ask the patient to close, he or she will close properly. But as soon as you put the material and ask the patient to close, they'll close like front, side, everywhere in the world, but in proper centric, because their mouth is full of material, right? So they also panic, and your material is setting in, you're also panicking. So that that is also something where centric goes wrong. And then the transition line between denture acrylic and reline material, that is sometimes in some areas it's a little bulky and we use a BP plate and it's rough. Now, if it's rough and there is no way of, smoothing it, and the burr which we are using, it's not working, then what to do? So that is also one thing which causes a lot of problems. So these are the things which you're going to face when you're going to, do your first reline, or you're going to go back to relining your denture. Now, positioning, as I said, is very important. Make sure that the material which, you've trimmed the denture evenly. Make sure that once you have filled the whole thing with material, you place in a certain way, and make sure that somehow the patient bites properly. Now, it's so easy, to say all these things, but how to actually do all this in the patient? Check, check your bite. Make the patient practice once or twice, and make sure, always make sure that at least one denture is stable. What does that mean? It means that if an old denture patient has come and you have to, let's say, okay, you have to reline the lower, right? But upper is also not stable. Ideally, he should go for a new one. But in our country, nothing is ideal, right? So if you have to reline, patient says, can you reline my lower denture? My upper denture is very good, he says, no problem. But my lower denture keeps coming out. You have checked everything. You say, okay, I think I'll have to reline it. It's hurting me somewhere. I've come so many times, doctor. It keeps hurting me. And that is when we say, okay, I'll reline it for you. It'll become soft and it's not going to hurt. Okay, that's what we tell him. Now, if your upper denture is unstable, and and lower, you're going to put material and ask him to bite, that's nothing will work, because upper is also not stable. And now patient will tell you, now my upper is also not sitting as when I bite because of your reline, right? So more problems. So what do? We have to stabilize the upper denture. How do we do that? See, unstable denture means that the bone is low somewhere, bone is high somewhere. Extractions of posteriors were done earlier. Extraction were, and anterior teeth were there longer, so there's more bone there. It's uneven, and denture is not stable. So in those areas, just take small 3 putty pieces, rolls, and put it in like a 3-point thing in anteriors and posteriors, and press the denture. So what happens is, it becomes even, right? And make the patient bite. After it sets, take it out, you'll see something like this. Now the denture is stable, even. Place it in the patient's mouth, it's very thin, and now you do the second. So make at least one denture stable before relining the opposite arch. Now, as I said, positioning of the denture and biting in centric, they're all happening together, right? How to manage that? Because without the relining, patient can bite properly, but with the material inside, patient is not biting properly. So always I would recommend, take your bite registration material. Okay, any bite registration material, does not have to be silicone or any particular company. Whatever bite registration material you have, just inject it or heat it and place it between the dentures. Ask the patient to bite. Once the patient bites on it, let it set. Then what happens? You remove the denture, whichever you want to reline, and let the material, this bite registration is ready. So when you have loaded the material, patient is in supine positions, partially supine. You place the denture, the bite registration material, and make the patient bite onto the bite registration material. So what happens is, when there are indentations and they are proper, patient is going to bite properly into the surface that has been created with the bite registration material, and then the chance of patient shifting and going here and there is reduced. So you're going to get proper seating. All right, this is also important. Now, seat denture properly anteriorly. Anteriorly basically means that you make sure that if it's an upper, you usually put anterior and then press it back so that the material flows back. Yeah. Slowly rotate and posterior into place. Ensure denture is not too far forward. But this basically means that denture is in place and it's not too forward, because many times we place it and it's not even gone in properly. All right. When both upper and lower denture need relining, usually lower denture should be done first. Now, how does it make sense? Because usually, as I said, one denture has to be stable, right? So if in most of the cases, because of lack of bone or presence of tongue, whatever the reason, the lower dentures are usually the ones needing reline. And if you have to do upper and lower both, usually the lower ones are less stable. So stabilize the upper the way I told you. Do the bite registration, place it, and then always do the lower first, because that is the most unstable. Once you make the lower stable, then you can reline the upper. So first do the lower relining and then the upper if you have to reline both the dentures, okay? Both the arches. Now, as I said, transition line between denture and reline sometimes gives trouble. So there's a short video which I have made because I tried doing it many times. When we are using a burr, it just becomes rougher. So whichever material, as I said, you are using, this material is flowing much easier because this is low viscosity. This is Tokuyama medium tough. The one which I had used earlier was Mucosil, and I find the thickest which I've used is DMG's Silicon Comfort. Now you see this excess, this is set, this excess material is come out. Now in the mouth, obviously it's not going to be like that because cheek and tongue and tissues, so it's going to be much smoother and nicer. It's easy to cut. But when you have some areas which are thicker, like in this, so the material, you are doing it, but it's not happening. So it's much easier to use a scissor. Take a sharp surgical scissor and cut the excess. Okay, don't use a BP blade if the material is very thick. It's just easier to cut that excess thickness. Okay, once we have cut the material, the areas which we feel the junction between the acrylic, the denture acrylic, and the silicone, if you feel that is rough, okay, in spite of using a very nice sharp scissor, in spite of using a good BP blade. So as I said, there are some burrs that are available by the companies. I have only used a silicone buff, but I did not use any burrs, but there are Molosil, there are some burrs recommended by companies as well. So if you have these burrs, you can try them and let me know as well. I have not tried this. It's not available in India. This I have. This you can easily get. This also I don't have. So I don't have these steel burrs for soft reline trimming. I just have the silicone buff. But I do feel that some areas which, it's difficult to remove with BP blade, I found that it is, see, how do you merge it? What if I can melt a little bit of the material? Now, this is not really given in any book. I just tried it and it worked. So the areas where, sometimes patient comes back and says, it's just a little rough in the tongue, and you cut it with a BP blade and it still remains rough, it's not working. So you heat the BP blade. Obviously, like it sounds, because it's a soft material, right? It will melt a little. Like, see, if you heat the BP blade, I'm heating the blade here, you see it's become black. Then very thin areas I can cut without any difficulty. See, it's much simpler to remove these small things which irritate the patient's tongue or the buccal mucosa, right? So if nothing works, just heat the BP blade. You don't have to buy anything. All of us have these blades, and just heat it up and trim it, cut it off, and then you're sorted. Yeah. So this is just the lingual flange, the same thing, just the same model, just showing how to do it. See how easy it is because you're heating the BP blade. Okay. A lot of companies also have gloss or varnish to merge these borders. So every company doesn't have. Some have, some don't have. So you can use those as well. But I personally feel if you just heat it up, it works fine. You don't really need to buy anything specific. Yeah. Okay. Now I'm going to show you some of my cases. Also the reason I'm showing is because you can see some of the cases have been done in a charitable trust. I do a lot of dentures in a charitable trust. I've been going since last 12, 13 years. Because in clinic, usually these things go for implants, right? Very few patients in the clinic for dentures. But the point is that every patient does not want to go for implants. Every patient cannot afford to go for implants. And if you can do simple things, why complicate, right? In some cases, don't push people to go for implants. So the reason I'm showing you this case is because of this, because she had very high frenal attachments, and the mucosa on the bone, on the lower bone, was very thin. So I knew that she's going to have problem because the denture will keep lifting and will hurt as well. She did not have much. So this is one of the reasons, I made a regular denture, but I had told her initially that we may have to do a soft chair side reline. I may have to soften your denture surface. But and we have to tell the patient initially that it is not permanent. This material needs to be changed every I always say around every once a year or 1.5 years, because sometimes in 9 months also it goes, because you know, you don't know the patient's upkeep, how is he keeping the denture, and how are they brushing. Sometimes they brush the reline. There are a lot of issues. So usually I say around 1 year, once in a year, once in 1.5 year, you have to change it, and that's the time when I change it. So here, this is the upper, this is the patient, just the basic impressions. So this is her. So basically, if you have high female attachment, this is the another case which was sent to me because the patient could not afford to go for anything else, and he was very old. The issue was, you can clearly see that he's had surgery, and we did not really know, he couldn't afford anything. He just came to us for dentures. So obviously, I cannot give him a regular acrylic denture. If I do that and I don't reline it, it's going to give a lot of trouble. So what I did here, I use a functional impression material for border molding. Basically, I used like a similar to an all green technique. I filled it with material, with functional impression material. This is DetaSeal Function by Detax, and I did the border molding. I did not use any light body on top of it. This is the upper. Right. So what I'm showing here is that I know how much it's going to hurt the patient when the denture moves. So I was mentally very ready, and the patient was ready to go ahead with soft relining. But as you can see, in this case, if I have a very flowable, very low viscosity material like Tokuyama, the material, the thickness and the cushioning that I need, I will not get. So in such cases, we have to use a higher viscosity material. So here I've used the MT Silagum Comfort, and the patient was comfortable. Obviously, he could not eat everything, but this was what we could do for him, and he was comfortable. This is another video that I want you to see. Now, there's not much of a ridge. There's not much of a vestibule. You can, there was not much vestibule, because if you have an alveolingual sulcus, we can get a nice suction and things are good. But if there's not, the sulcus is not there too much, then it's a problem. So this is a reline, soft reline denture. This is just to show you that, in such cases also, when you think alveolingual sulcus is relatively shallow, those cases also we can use soft reline, because it flows and goes under the tongue and it remains high. So the denture, you can see, is pretty stable. And once we take it out, you can see this pink thing. Yeah, so that pink thing which you saw at the borders, that whole thing is the chairside soft reline, which I have used for the patient. So this patient was comfortable with this. So, because as you can see, it's very stable, difficult to take it out. So reline kind of gives you very good retention also if the borders are done properly. Okay. You see this pink thing here? That is the soft reline. Yeah, this is another case. This was pretty interesting because the patient had a denture. He already had a denture. It's not, I've not made it. I can see that VD is more, the lowers are very high. But it was hurting him, and he said that I cannot get any surgical thing done. And we relined it for him, and he was very comfortable. So why I want you to see this case is because I want you to see the ridge. Okay. Once you see the lower ridge, you'll understand why it was hurting him, because the doctor who had done the extractions did not do any alveoloplasty, did not remove any bone, and you can see how how it was, right? So as you can easily see, I'll go back here and I will play, because I want you to see the bony spicules here. Okay, now you see this. Obviously the denture is going to hurt. Now this is obviously an extreme case, but in let's say non-extreme cases also, where there's you can reline, but this is definitely a case where nothing would have worked except the reline. Now this is, I'm not going to go into the details, but you can just see that this is actually more than 5 years now. It's 8 years old, this case. This patient is also no more, but she's one of the patients who's, I've known her for a very long time, and so she had no ridge and she came to me. So I told her, I cannot make a denture for you because there was no vestibule, there was no ridge, and we're not magicians. There are cases where, patients are not happy. And I told her, I don't think I can make you happy. And she said, you try. And I told her, if I do, this is her upper, I will have to reline it. So we relined it. And after 5 years, you see the ridge now. Yeah, my camera quality has improved. But the point is that in such cases, she was wearing the same denture. You see, this is an old denture I gave her. And this is the reline, which obviously I relined it a couple of times in those 5-6 years. But the relines work in cases where nothing is working. So I'm not saying become Superman and promise things, but when nothing is working, this is something which will work. Patient comes back again and again, but if you reline and it's done properly, your patient is gone for a year. He's comfortable, right? All right. So this is another case of mine. She is my clinic patient. She's been with me for a long time. I have documented for like 7 years or something for her, but she's also with me for a very long time. So she had this is how she is. She had an upper RPD and FPD, natural tooth. This is the bone, and she's a laryngectomy patient. She doesn't have a voice box. She cannot go ahead with any of the surgeries. Only thing she can get is a denture, and she had a major phobia of not having any teeth. So we told her, okay, you'll need dentures, and she said, no, I don't want you to touch my upper RPD. It's perfect. So I told her, your upper bridge is not going to last for too long. She said, it's all right. You just do the lower. So we did extracted these 3 teeth, and we did functional impression technique like a quasi neutral zone. And that's not the topic today, but just to show you that this is a pre-existing FPD, this is her RPD denture and a natural tooth. And and we relined it because there was nothing. So I said, you manage with it now. And after 6 months, her upper bridge came off. And she had severe fear that she'll have no teeth. So within like 2 days, 2 to 3 days, we made a denture. We did an immediate denture and immediate placement. That is why you see that the teeth are not in line. This is not very aesthetic because this was a immediate denture case. But the lower was same. The lower was same, and it was working. Now, obviously, she cannot have hard things, but she has no bone, and she is okay. She looks all right. Now, this is her immediate denture, and then I told her we will keep relining it because it's an immediate denture. Initially, I put the tissue conditioner. These are the cases for tissue conditioners, right? Because you want to heal the tissue. Don't use a permanent reliner. And then she told that she was happy. She said, I want, when you make my new denture, it has to be whiter teeth, and I had gaps. So you give me gaps. So this is her final impressions. This is upper, this is her new lower. Now you see it's rough. So I had discussed how to maintain the VD. Now here, if I'm going to trim the whole thing and she's going to bite, the material is going to flow out, especially if it's a low viscosity material. So what I have done, if you can see here, see these areas, these one, this is the second, and this is the third area. You can see these areas here, these areas are not cut, they are not trimmed, they are higher than rest of the things. So you maintain these 3 areas to ensure like a three area stop, so that when the patient bites, the material on these 3 areas is going to be very thin, but rest will be thick, okay? So that your VD is maintained. So this is how it is done. This is, done. And we gave her spacing and everything, and she was fine. And this is what we did for her. And then again, she was back in 2019. She said that the denture is not fitting again. So every year I used to reline her lower. Upper I didn't reline. Upper I had used the tissue conditioner earlier, but later I didn't. Now you can see the resorption has progressed so much. Her chin is jutting out. And yeah, so this is, it doesn't fit anymore. She said, I need new dentures. And this is her upper. This is her lower. Now nothing is left. We did again. Yeah, upper she didn't want to change. She just wanted to change the lower. So this is the lower. Upper, I just made the impression for the lab, and we just poured a little bit of alu wax to get proper indentations, because in modeling wax many times the trial doesn't come properly. So this is how it's done. And this is reline. Now you see this relining is so much thinner than the one which we did earlier. That means she's lost more bone. Okay. So you have to be within the physiological limits, and this is relined again. So this is August 2019. She met with an accident recently, so now I've not documented, but hopefully when I see you for my next lecture, I would have documented, because she's come back to us in 2021 as well. All right. So this is on relining a little bit. I know it's just 1 hour I had, so I've told you small tips and tricks as to how to do it and what are the indications, where not to do it. But it's just a much bigger topic. and 1 hour is not enough, because I have learned from my own mistakes and I don't want you to make those mistakes. So if you are free, then I'm coming to your side. I'm coming to Kerala in January. So if you want to learn about post-insertion problems without relining as well, and their solutions, in which I had taken a webinar on this also, which went on for more than 1 hour to almost 1.5 hours that day, because again, it's such a big topic. If you want that I discuss the whole thing with you in person, we will be taking patient demonstrations where I will be showing how to do single shot border molding with functional impression material, and easy ways of doing jaw relation, so that most of the things in jaw relation I do outside the patient, and then just the final thing inside, because the more work you do outside, the easier it is. Patient is relaxed and less stressed and muscles are okay. And we are also going to have a hands-on on models where you can use the chair side soft relining material, get a hang of it, how to actually use it before you experiment on the patient. And I'm going to show you a lot of cases and videos. So if you are free on 28th and 29th of January, do join us. If you have any doubts, which I am sure you do, I will try to answer some of them now, and some then you can share with me, and I can probably answer on Facebook as well. Thank you so much for your time. Thank you.
Okay, thank you so much, ma'am, for your sharing your knowledge and expertise when it comes towards relining
Dr.
and
Shanoop, I'm
loose.
done. Okay, so not much doubts.
Ma'am,
Right?
I think it's not audible for you.
All right,
Okay,
so
I'll just.
Dr. Shanoop, can we start with the discussion, question answer session? I can't hear anything. Just a second. Hello? I can't hear anything. Okay, let me just put it. Let's see. Just a second.
Okay. Is my voice audible now, ma'am?
Okay. Can you hear me now?
I'm able to hear, but are you able to hear?
Who's the thing? It's not coming correct.
Okay, okay.
Can you just try? Okay, so this is funny because I can't hear anything somehow. So if
Okay.
it's okay,
Okay, it's fine, ma'am. Yeah, sure. Okay, okay. Okay.
sorry, what did you say?
Yeah. Yeah, I'll try to read out the questions, ma'am.
Okay.
Okay, fine. So
Doctor, if you read out the questions, I won't be able to hear what question you are asking because I can't hear anything.
Okay. So I think we'll have to call you again.
Hello?
Hello? Hello, ma'am? No.
I can't hear anything, so I think I can just read and answer the questions which I can see because I can't hear anything. Yeah, but if you switch off the phone, then I can't hear anything. Yeah, okay.
Okay, so one of the questions. Okay, so I'll read one of the questions. Okay, one question is, what is the approximate cost of those relining materials?
All right. So the cost of relining materials is it varies a lot. So if you are using a hard reline, a good company hard reline in the sometimes if the PPS is not good and all, and you want to just reline use a hard reline, it costs somewhere the whole box, which can be used for a long time. It has a 3-year expiry. That costs somewhere around 6,000. But if you want a soft reline, the cheapest ones like the Reviver from Detax, it costs somewhere around 4,000. But the best one, that is Tokuyama Medium Tough, it's very good material, but it is quite expensive. It costs somewhere around 8,500. But you can use it on a lot of patients. So if you want to just try for the first time, I would suggest you go for DMG Silagam Comfort because it is in the range of around 5,500. If you want to try, you can try a Reviver or that. But the more expensive one is Tokuyama, which is, and GC is also expensive. Then the range of around around 8 to 8,500. But it's really worth, because you don't, if that those patients where it is hurting again and again, you can place it and they are very comfortable in that particular area. Yeah.
Okay, ma'am. So the next question, do you prefer doing ridge expansion for narrow ridge?
I can't see the question. Ridge expansion for a narrow ridge. So that is like ridge expansion is basically when you can do, pre-prosthetics. That is, you can do vestibule cast. You can make the vestibule deeper, and you can expand. And you can see ridge expansion. There are two ways. You can increase the width and you can increase the depth. The depth is where you are moving the soft tissues down, and you have enough space now. You have enough depth of the vestibule where you can get proper suction. And increasing the width is something very different, where there are different techniques to that. But the thing is that all patients are not going to be comfortable with that. So yes, moving the tissue down, I have tried doing it sometimes, but my personal experience was not that great. I felt that there was scarring, or it would bounce back sometimes in my cases. But that may also be because I had, maybe I did not, maybe because the surgeon I was working with, I wasn't very sure if it kind of scarred in one of my cases, and it bounced back in a couple of cases. So personally, if it's not really needed, I'm a little skeptical about doing it. Yeah?
Okay, ma'am. So the next question is, can we correct only the denture extension with relining materials?
So, do you mean that only denture extensions, but not put it inside, just on the borders? Is that the question?
It's just mentioned denture
Okay.
extensions.
So, all right. See, denture extension you can correct, but if you're using a hard reline or a soft reline, you cannot, like for example, borders, denture extensions mean borders and bone, right? So you cannot put material only on the borders. That means the material sitting on the borders and going to slip off. You may put whatever adhesive, it's not going to stay. You want this whole sheet of material to go in and come out outside the borders, okay, where you can keep it. But if you're going to have the material only on the borders, it's not going to work. So there are two ways of doing it. One is where you don't involve the borders, you can do that you create a ditch around it and fill it in. And the second one is where you have to correct the border extensions. You have to use it completely. The whole denture has to be relined, not just the borders. Border extensions, you have to reline the complete denture. Okay. All right.
Okay. So the next question is the difference between a soft reline and a tissue conditioner.
Okay. All right. So, difference between soft reline tissue. See, tissue conditioners and soft relines are same thing in the sense they are soft. Okay. The major difference is that one can be used only for a little while, and the other can be used for much longer. Now, the tissue conditioners are way cheaper than soft relines. Okay. For example, if the GC permanent or long-term reline, it costs somewhere around 8,000. The tissue conditioner will cost around 3,500 to 4,000 or 4,500. So whatever company we are using, so that is the financial thing. But when we are working on the patient, a tissue conditioner is much thicker. Okay. Also, it absorbs things. So that means if the patient is having haldi, patient is having coffee, all those tannins, all those things will get absorbed, and slowly the tissue conditioner is going to become thicker. It is not permanent. Okay, it is, for example, Tokoyama has the tissue conditioner which they claim lasts for 6 months, and their reline lasts for 2 years. In my experience, their reline lasts for 1 year, 1 year and a half. Their tissue conditioner lasts for 3 to 4 months. Okay, so tissue conditioners are for short term where they are thicker, they are higher viscosity, and they basically, if there's an extraction that has been done or an implant that has to be put and you're putting a denture on top, so it kind of distributes the stresses and does not put pressure or does not impinge on those picules or areas where you don't want pressure. Whereas a relining with a low viscosity will flow everywhere. Okay, and put pressure also. So tissue conditioner are for healing and conditioning the tissue, and relining is for having a newer surface which the patient is going to wear the denture for a long time.
Okay, ma'am. Would you suggest how much we can charge per arch of relining?
That is very vague, no?
Mhm.
All right. So, how much we can charge actually depends on the two factors. Okay. One is what is the cost of the reliner you are using. If you are using the high end one, you will have to charge more. Now, lot of doctors tell me that how can I charge more? It is so. I'll tell you something very funny. Recently, because I don't do relining for all my patients. Most of my patients I don't do. I only use them where I feel that the problems are not going away, or I feel they are a specific, different, difficult case where it is needed. Okay, so in those cases I do. So the point is, I tell the patient before I start the treatment that there is a high chance that there's no bone, or there are spicules, or there are high field attachments, and you're not going for previous prosthetic surgery. So I tell my patients that I'm going to use a reliner. I'm going to make, they don't understand reliners, right? So I tell them I'm going to make your dentures soft from inside. So now there are, how all the ladies talk. I actually get people, old denture wearing aunties, and they tell me, can you make my dentures soft? My dentures hurt. So they are mentally prepared as to that they have to pay more because they are getting something special, okay, which is not going to hurt, which is going to be much better. And they are mentally prepared to pay me every year. Okay. So how much to charge? It will also depend on the kind of practice you have. If you are using a cheaper one, let's say a 4,000 reviver, and you can do at least, 7, 8 dentures with that, you can charge somewhere around three. But like for example, if I'm doing it, I usually charge around 4,500 to 5,000 per arch, because if I do one upper and lower, I just recover the cost of my reline. Yes, already made money in I've made the denture, so I've already made the money. So this is something to make my headache less and patient comfort more. So people charge somewhere between, like, I charge six also, I charge seven also, I charge three also. So it all varies, or but I think somewhere around 4,000 per arch is okay, because we've already charged for the denture as well. This is my personal opinion. It will vary for you, I guess. Yeah.
Okay, ma'am. So the next question is how frequently we should change the relining material?
Okay. So see, as I said, usually tell the patient that we are going to. You should tell the patient that we might have to change it once in a year to year and a half. So usually in 1 year to somewhere around 18 months you have to change. So my longest has been actually 2 years and 3 4 months, that patient. And then I have patients who have relined long back and they've not come back, and when they come for get their children or something, and I show their reline is actually, I can see that it is spoiled now, and we need to do something about it. But they don't want me to change it because they are like, I'm comfortable with it. So I tell the patients 1 year plus is what is a safe bet, because if something goes wrong in, let's say, 9 months, 10 months, you are close to that year, because everybody does not maintain the dentures that well, and you have to tell them not to use denture cleansing tablets and all of that. It will start peeling off more. Okay, so just be careful about all those things as well. Yeah.
Any post relining cleaning instructions to be given to the patients?
Yeah. So post relining, if you are using permanent silicone relines, ideally they can use a muslin cloth, or I just tell them to use finger, and they can use soap if they want. But they are not supposed to use denture tablets or put adhesives and all. I've had patients who put adhesives and the whole relining is peeling off from the thing. So don't use any chemicals. They can use soap, and they can use water, and they can use muslin cloth if needed. That's it. Yeah.
Okay. So I think, ma'am, we are coming to the end of the question answer session. I think the last question is, do you prefer chairside relining or the lab relining?
Okay, so
And
I'll
huh.
say this last and then we finish because I'm looking so funny. I'm literally coming to phone and and then I'm talking. So
Yes,
okay,
ma'am.
hold on. All right. So when I started my practice and when I finally discovered relines and I understood how it is to be done, I thought maybe I should do a lab soft reline. Okay, so if I have to do a hard reline, I prefer a lab reline. I do hard relines in the clinic also if I'm short on time or if I feel, because it's a very good hard relining material, the Tokiyama hard reline, and it lasts you for 3 years. So I actually, sometimes you feel that okay, PPS is not, it's not good. So in that, what I do, I put green stick or and I check with that if the PPS of the which by just adding the PPS, if I feel that the denture suction has improved, then I remove the green stick and I just put a little bit of Tokiyama. It just looks like a denture. It does not get spoiled. It's very good material. So that is also one thing. But if I'm using soft reline, chairside reline, I always do it at chairside. I do not send it to the lab, though, because initially I tried and I sent it to 2 labs and they were good labs. I'm not going to mention, and both of them spoiled my dentures. So I feel personally that most of the labs are not well versed with doing soft relining. I would strongly recommend that you do it chairside yourself. It is not so difficult, and when you have done it, your patient is immediately comfortable and happy. And you can make the changes. You are doing it in the mouth, right? Making an impression and sending soft reline, it is not. They're not. The pressure is not going to be the same. But when it's a soft reline, in my hands, it's always chairside, always.
Okay, ma'am. I think now some questions are there which are actually out of topic, but we'll try to answer them in any other social media platforms. Right,
Okay.
ma'am?
I'll just
Fine.
answer one. I can see hard reliner brand. I personally have Tokuyama hard reline, which is amazing. It does not heat up. It comes with something to harden the acrylic also, and I have used it for many years now, and it does not get spoiled. It looks exactly like the denture. You cannot make out where the reline is. And I'm not trying to sell Tokuyama. I just use the material. I like it. So denture materials, I know Tokuyama has composites, which are good, but I like the denture materials. So it's just that that's a good one to buy, and it's not that expensive compared to the soft ones. I think we're done. Yeah.
Yes, ma'am. So thank you so much for sharing your knowledge and expertise. So definitely many of us would leave this discussion with amazing takeaway points and implement techniques as per discussed. So if anyone is interested to have a deep insight and learning about complete dentures, we do have a simplified workshop happening in Jan 28th and 28th and 29th. I'll just share this screen. Yep. Yeah. So as you can see, the mentioned topics, these topics will be discussed in the workshop. And this program will give you deep understanding in each and every step of fabricating a complete denture, including relining. So if anyone is interested, you can contact this mentioned numbers for the registration. So once again, thank you so much for your time, ma'am. It was really informative. And thanks to all the doctors who had attended this webinar. And I hope all of you will depart this session in a positive, confident manner.
Thank you.
So thank you all and have a great night.
Thank you. Bye.